There's a laser pointer.
Sorry, here, Scott. You know. Are you first?
No, I'm the last one. This one doesn't have that. Thank you.
Yeah. All right, good afternoon, everybody. So happy everybody's here. Welcome back to our second day, Tuesday, April 18th of our session. I'm Alicia Mangrum, and I'm going to let Dr. Frank Wood introduce himself, and I'm going to let him kind of run everything. But I do want to just make one announcement that we're super excited about a great party this afternoon. So the reception, the dinner, everything's going to be here this afternoon. So please come and enjoy. And the biggest thing is the dancing, because everybody hadn't been dancing lately. I don't know, COVID scared everybody, but I'm dancing. So we're all going to dance tonight. That's they made sure that I make that announcement. So welcome everybody to scientific session number 5. I'm going to turn it over to Dr. Wood.
Good afternoon. Yes, I'm Dr. Wood from the University of Oklahoma. For session 5, the first presentation that we have, Dr. Crawley from the University of Colorado is presenting traumatic brain injury endotypes, polytrauma TBI results in distinct pathway activation compared to isolated TBI.
All right. Thank you for the introduction and the opportunity to present today. Our lab is funded by the NIH and the DoD. The interactions of polytrauma, hemorrhagic shock, and traumatic brain injury are poorly understood. TBI activates our systemic inflammatory responses, such as the coagulation and the complement system, and then it also changes our metabolism and our endothelial barrier responses. Additionally, hemorrhagic shock and global injury exacerbate these same systems, and you get positive continual feedback of our body's thromboinflammatory responses to injury. With so many pathways activated and contributing to the pathologic sequelae, it's difficult to identify potential targets for future interventions to improve our trauma outcomes. But recently, omics techniques such as proteomics, metabolomics, those have become front and center in our toolbox because they help us identify hundreds of molecules and pathways at once. And they also help us generate multiple investigational hypotheses regarding our trauma milieu responses. So using our own proteomic and metabolomic databases, we sought to identify key biomarkers in TBI and identify potential mediators driving TBI-induced thromboinflammatory responses. So for this study, we collected blood from trauma patients who were admitted to our level 1 trauma center. Blood was collected upon arrival at the emergency department, and it's stored as platelet-free plasma that's paired with a prospectively maintained clinical database. For this study, we grouped patients into TBI groups and non-TBI groups. We additionally further subgrouped them into minimally injured, isolated TBI, and polytrauma patients with or without TBI. For that plasma, it underwent mass spectrometry protein identification. For those of you who aren't super familiar with this process, the platelet-free plasma undergoes protein digestion first before going through that mass spectrometer that's coupled with liquid chromatography. As molecules flow through that device, the mass spectrometer measures the ionization and the speed of those molecules, and it generates a data library. We take that library and we query it against a human proteome, and we identify the protein names and the relative associated protein levels. And then the metabolomic process is similar to this basic proteomic procedure. Starting with our proteomic results, we identified 793 different proteins in our 4 groups. We selected the top differentially expressed proteins, and we further identified that those that were most heavily upregulated and those that were downregulated in TBI. We then performed a random forest plot model, which identifies the most important proteins associated with TBI. And we performed a proteome-wide correlation with AIS head and neck. Using this type of analysis, we were able to detect some known markers of neuroinflammation, and those proteins included neuroplexins, synucleins, apolipoproteins, and VCAM1, for example. We're particularly interested in these proteins because they all have roles in maintaining the blood-brain barrier, And they also suggest potential mechanistic pathways that can be further explored in the setting of TBI. So looking at VCAM1, for example, VCAM is upregulated in TBI through the metalloproteinase pathways. Increased VCAM expression leads to increased leukocyte signaling, and VCAM receptor activation leads to Rho and RAS signaling activation. And then ultimately you get endothelial cell contraction, loss of tight junctions, and leukocyte transmigration. And that's why we have blood-brain barrier dysfunction in TBI. Switching to our metabolomics, we identified 159 different metabolites, and we again looked at the top differentially expressed metabolites. We identified those that were most heavily upregulated and those that were downregulated, and we performed that random forest plot to identify the most important metabolites associated with TBI. Of these VIP metabolites, we were particularly interested in the strong presence of conjugated bile acids and metabolites of potential bacterial gut origin. Why did these interest us? Well, TBI is associated with decreased splanchnic perfusion and increased gut permeability. That leads to increases in bile acids and bacterial metabolites in our circulation, serving as some unusual biomarkers for traumatic brain injury. But clinically, what does this mean for our TBI patients? Well, bile acid accumulation is associated with coagulopathy. Specifically, we see hyperfibrillation, poor platelet inhibition, and poor clot strength. So this suggests that TBI-induced bile acid accumulation could be linked to TBI-induced coagulopathy. And that potential link could be the platelet adenosine diphosphate receptor pathway. Under normal physiologic conditions, ADP binds to the P2Y receptor, activating our platelets. However, in the setting of increased bile acids, this pathway is inhibited, and that leads to poor platelet activation in our TBI patients. So where do we go from here with this type of proteomic analysis? Well, first we've shown that plasma can reveal early TBI-induced metabolic and proteomic changes. Omic results can help us detect potential biomarkers that aid in the TBI diagnosis, and they can suggest potential early mediators behind TBI-induced thromboinflammatory responses. And lastly, we can use omic results such as these to provide the framework to further explore these potential mechanisms in the lab, and then we can identify potential targets for future interventions to improve our TBI and trauma outcomes. So I thank you for your attention, and I'd like to take any questions before I go back to the lab and explore some mechanisms.
And to discuss this paper, we'll have Nicholas Milo.
Hi, Nicholas Miller from Cedars-Sinai. Dr. Crawley and your group, excellent work. As a former basic scientist, it made me realize I can't just look at this paper and ask questions. I actually have to read and learn and look up even what half these words are. But all that said, just so you know, thank you to Dr. Crawley and her team for getting me the manuscript ahead of time, because that's where most of these questions are based. But while I did that, I learned that Dr. Crawley is also getting her PhD, if I'm correct. So kudos to you for helping to elucidate these mechanisms, because similar to an opinion piece that I read this morning about a transplant patient that's dying, a lot of the advances have been nil in the past 40 years. So for such an ongoing process, thank you for all your hard work. So more so based on the manuscript, in the methods, is that standard to remove? You said you removed variables which are 30% values that were missing across the samples, then imputed the missing values with 20% lowest value per variable. Is that, do you think, just because of all the processing, or is it just the time point that you didn't see that those variables were there? And if so, was this data analyzed with that 30% missing? And I can go through all the questions because I also sent them to her and not surprise her. In the results also, why do you think the patients with TBI had an elevated INR yet TEG parameters were similar? Just how do you account for this? And then it also seems that with a relative young average age, I believe it was in the 30s, compared to some other papers with TBI where the average age is in the 50s, does elderly head trauma, which plays a significant trauma burden, was this even factored in? And in addition, in your data sets, was there any mention of anticoagulants such as DOACs that could affect your results? This is straight from your discussion. The lack of highly significant proteins in these cohorts could be explained by the fact that our proteomic techniques and database did not identify any of the most commonly studied and well-known serum and CSF markers for traumatic brain injury. Is it suggested that the lack of finding them means that they didn't exist? Or could it be perhaps that the methods of using platelet-poor plasma, which is also significant in TBI, or is it the timing of the samples? And I know you discussed this in your limitations. I'll skip the apolipoproteins question. And then the last one, with the presence of the elevated SLC4A1 in the TBI plasma samples compared to controls suggests red blood cell lysis in this cohort. And I know you mentioned that normally with red cell lysis, you'd have elevated levels of potassium and LDH, yet your samples did not. Do you think that, are you suggesting that you are finding that red cell lysis is an ongoing process, or is in fact this just due to the initial mechanical injury and shearing of the red blood cells? And is SLC4A1 only expressed in red blood cells? So hopefully that sounds like I know what I'm talking about, but I do commend you in your group for such an excellent paper, and the Southwest Surgical for giving me the opportunity to be the discussant.
Thank you. So I'm going to tackle those questions in that order. I'm going to start first with the explanation of our missing variables, and that refers to our proteomic data set. And when we have our plasma samples and we have proteins that are below the detection threshold that we've set for that mass spectrometer, when the data comes out, it's a missing variable. And so instead of treating it as a 0 and suggesting that that protein doesn't exist, we change it to 20% of what that baseline detection limit is. And we do that specifically for this type of discovery analysis where we don't want to remove any of the proteins that we're looking at and trying to determine their significance and how important they are. But if we were doing a different analysis and we were specifically interested in one of those proteins that do have greater than 30% missing in our samples, we could actually do a different analysis, such as converting the variable to cutoffs and categorical cutoffs, below threshold, above threshold, between this limit, and then another range. So we can adjust for those missing variables in different ways depending on the analysis we're doing. Regarding coagulopathy in this data set, it's not unusual for INR and TAG data to always not pair perfectly. PT-INR measures the extrinsic pathways, while our TAGs use kaolin, which activates our intrinsic pathways. So that specifically is the R time and the INR might not pair up well. But probably most importantly for this data set is all of our patients had INR, but not all of our patients had TAGs. We're looking at about 85% who have the TAGs. And those patients that don't get TAGs are the ones who are least injured. So we've probably self-selected our patients there in our TAG outcomes. We did not look at age as a factor in this database yet. We looked at anticoagulation, and I think it was 4 patients out of the 232 that had appropriate samples. So we didn't account for that, but we certainly could go back and confirm that it doesn't change our results. The next question, the more commonly known proteins that are associated with TBI. And this was actually my #1 question for our proteomics team, because we did not see GFP in this database. And there's a few other ones that are more commonly known. But I've learned after speaking with them that commonly known doesn't mean most abundant. So this is an untargeted proteomic analysis in which, when you think about the plasma proteins, we have 60% of it is albumin. And then the next 30% are immunoglobulins, some lipoproteins. And then really that almost 800 proteins that we identified, that's the bottom 10% that exist in our plasma. And so in order to collect as many proteins as we can with getting rid of some background noise, the mass spectrometry settings are what my proteomic PI calls untargeted analysis. So a lot of those smaller, less abundant proteins like GFP, which is present in TBI patients, but you think that our TBI patients are less than 50% of our samples, it really can't compete with the more abundant proteins in this untargeted analysis. But if we were to change the mass spectrometry settings and target that protein, we would be able to identify it and it would be very significant, but we just didn't do that in this type of proteomic procedure. And then the last question regarding the anion exchange band, SCL4A1, I might have gotten that alphabet soup wrong off the top of my head, but that protein is expressed in erythrocytes and it's also expressed in kidney cells in the distal collecting tubule. And the reason why we think it's hemolysis is because we also see other indicators of hemolysis, and we think that it is due to that mechanical process. Unfortunately, in this database, we don't have longitudinal samples to confirm that it's an ongoing process, but we would like to look at a different database and see if we can find something there, because we have done some work on hemolysis in longitudinal samples.
Yes, sir.
Justin Regner, Temple, Texas. Really fascinating work. You kind of answered the question, but really had two questions. One was, did you do longitudinal or time course studies over, the first 7 days of the traumatic brain injury? And then if you did that, were you able to evaluate patients that had prolonged NPO status versus patients who were fed early, or patients who suffered hollow viscous injury in addition to the traumatic brain injury, and how those patients' brain injuries have evolved over time?
Yeah, so we do not have longitudinal samples in this database. I think the next phase would be to go to our smaller database that does have longitudinal samples and do the same type of analysis in that database. But additionally, this first manuscript, we actually didn't look at really the outcomes and the different protein levels on those outcomes. So that is still left to do. And we've got to do the correlations as well, which outcomes are correlating with which proteins. So there's a lot left for us to do.
Thank you very much.
Thank you.
For our next, we have Dr. Watkins presenting from the University of Missouri, Kansas City Trauma. It is a party, but is everyone invited?
Hello, I'm Dr. Madeline Watkins. I'm a third-year general surgery resident at University of Missouri, Kansas City. And I will be talking about trauma today and trauma transfers. These are my disclosures. So as we all know, traumatic injury is the leading cause of death among those less than 44 years of age. In the last 40 years, we have discovered that transfers to higher levels of care have been associated with significant improvements in trauma outcomes. Not necessarily surprising. But who benefits most from transfers? And there's a whole list that you can read, but it's really the sick patient in the trauma bay that we've seen. And for the expert cases, that any of those patients obviously probably needed to be transferred no matter what. But not everyone benefits. There is a single-centered study that 53% of the transfers were discharged within 48 hours, and 97% of those patients did not need a procedure. Trauma transfers that are unnecessary are a burden to the patient, the system, and financially. There's a study that's across the border in Kansas that talks about futile transfers, and they estimated the cost to be around $56,000 for every trauma transfer that occurs, approximately. So the purpose of our study was to identify who is at risk for early discharge. Who's the patient that does not need to be transferred? In our materials and methods, we did a retrospective study from 2019 to 2021, included over 2,400 patients, and we differentiated those patients into a short stay group of 463 patients who were discharged within less than 24 hours. These are patients that did not require a procedure. They are excluded if they required a procedure. And then the other group was over 1,900 patients who were admitted and stayed more than 24 hours. So here's some statistical things that we did. We did a logistic regression model and created with backward selection to identify the factors that independently were associated with early discharge. So in layman's terms, we picked the most important features of each patient and added them all together and to come up with what's the risk of an early discharge. So we removed all the least important variables. And from those weights, we created a score, a simple number for those important clinical characteristics and added those scores to come up with who's going to be discharged early. So here are the patient demographics. I'll go through a little bit of it, but really it's not anything unexpected. The younger patient was more likely to be discharged early. Males were more likely to be discharged early, and usually the activation level was a consult. We did notice that injury severity score was important. In the short stay group, your score was around 5 versus long stay group was around 10. GCS didn't matter, and then vitals usually didn't matter. So with these numbers and all the numbers, we created odds ratios. And we found that injury severity score less than 6, you had the highest odds ratio. So you had the highest odds of being discharged early if you had an ISS less than 6. You also, if you look down there, there's a score of 4.37 that I didn't highlighted, which says external versus abdominal and extremities. That's really just patient who had skin injuries, and that was also a high odds ratio. So with those odds ratios, the beta scores, we turned them into numbers, and that was our points. Now, as you can see, ISS less than 6, and this external versus abdominal extremities, you had a possible score and face, possible score 5, 4, and 5. So those were high. Then we used the C statistic model and put these into percentages. So if a patient scored between 0 and 6 points, that's a sick patient. They have a high likelihood of probably staying in the hospital longer than 24 hours. So 4.8% chance of being discharged early. Whereas if you had a score greater than 15 points based on these clinical characteristics, you had a high likelihood of being discharged early at 67.2%. So with these simple characteristics, we kind of come up with a better objective way to identify who's at high likelihood of being discharged early within 24 hours. What are we going to do with this? Well, this was a retrospective study, so we need to validate it and put it in a prospective study. It's a way that we can implement teletrauma in the future, and it lessens the burden to the patient who hopefully will get care sooner, the system who's overrun with patients right now, and financially saving that money on the patient, especially if they do not have insurance. Limitations, this was a single-centered study. We couldn't determine the severity of the disease, meaning if someone said they had dementia, we don't know how bad their dementia is. So that is more subjective versus objective. And then it hasn't been validated in an independent sample. So this is where our prospective study will come into play. So in conclusion, approximately 1 in 5 of our transfers were discharged within 24 hours without intervention. We identified patient and injury characteristics that could predict early discharge. And we look to the future to do a prospective study to see and identify any rational transfers in a more objective way. Thank you.
Thank you, Dr. Watkins. For our discussant, we'll have Dr. DeVigilo from UCLA.
Thank you very much. And first of all, thanks for the opportunity to comment on this very interesting article. I want to congratulate Dr. Watkins and colleagues for their provocative work. Trauma centers were created to provide the appropriate level of care to injured patients and to do so in a timely fashion. Several studies support the premise that outcomes vary depending on the trauma center designation. Algorithms created by the American College of Surgeons Committee on Trauma recommend the transfer of injured patients to a higher level of care. This is supported by EMTALA, created in 1986, which mandates that once stabilized in an emergency department, patients must be transferred to a higher level facility if the initial receiving hospital lacks the resources to provide definitive care. The problem, as outlined by the authors, is that patients are frequently transferred who in retrospect didn't really need care at a level 1 trauma center and could have just as well stayed at the original hospital. This so-called secondary over triage wastes resources. In this study, the authors focused on this important issue of secondary over triage and identify variables that, as stated by the authors, if prospectively validated, may identify patients who may be safely managed without transfer. I have several questions. I know you mentioned a little bit in your presentation, but can you expand a little bit on how you intend to use these criteria? For instance, one of the important variables you found was the injury severity score. This score is typically not calculated at the emergency room of the referring hospital. Since your study, have you worked with your regional hospitals to help better understand the reasons behind over triage? Did you find that certain hospitals were more likely to be overrepresented as over triagers? In one of the studies that looked at over triage, they found that only 5 hospitals out of 72 were the primary ones responsible for over triage. And so they worked with those centers to try to identify problems. In addition, I didn't see that you had looked at insurance status as a variable. Did you have any data on this? Under triage is generally considered worse than over triage, as you want to make sure you don't miss getting the best and most prompt care for badly injured patients at level 1 trauma centers. As such, guidelines for field triage recommend an under triage rate of no more than 5%, though ideally it should be 0%. To achieve such a low rate, you have to accept a rather significant rate of over triage ranging between 25 and 35%. These recommendations, of course, are for field triage, not for interfacility transfer or secondary triage. So my final 2 questions are, if you try to reduce this secondary over triage, do you run the risk of secondary under triage? What, in your opinion, is an acceptable rate of secondary over triage? Thank you very much.
Okay, so the first question is, how do we intend to use this criteria in the future, especially when ISS, we know, is usually not calculated immediately, and that was used in our data. It's really, since this was a retrospective study, it's a starting point. It's really what we needed to use to look at our mechanisms of injuries and what's the pattern of injuries that we're seeing that result in these unnecessary trauma transfers. The next question, regional hospitals. I'll have to look closer at we do have every single hospital listed, so that'd be looking closer at that and seeing the patterns of which hospitals, like you were saying in your study, are higher likelihood of transferring. And then what hospitals over triage in that system? I'd have to look, but a lot of the times, since we are a large systems, the St. Luke's system is very large. It's usually just the feeder hospitals from either North Kansas City, South Kansas City, or East. So it's not necessarily the rural community hospitals as much. Insurance status, that wasn't one of our variables, but we do have one study that we were looking at that those that were not insured had a higher chance of being transferred to a level 1 trauma center than those insured, which is interesting. And those would be the patients that would benefit the most from this, likely if they're self-pay. How are we going to try to reduce secondary triage? Again, I think this is from the teletrauma always being in contact and communicating with those outside hospitals and never saying no necessarily. But if we do say, oh, I don't think it needs to happen right now, always having that option that they can call back if they're getting something's happening and they need a transfer immediately. And under triage, again, I think it's just going to be communication between these systems. There is a risk. I don't know the exact percentage. From the study we looked at, over triage was at least 33% at one point. So the risk of under triage, I can't give you a number right at that time. Thank you.
Ronnie Stewart, San Antonio. You know, philosophically, I come at it totally different from this paper. But I'll say the goals of the trauma system are to get the right patient to the right place in the right time with the right care, independent of funding. You did say in your talk about transfers, especially when the patient does have insurance. To me, it should be completely independent of funding status. And I believe the person who's in the best decision to understand where the patient needs to be transferred is the physician or person who's caring for the patient at that same time in the facility where they're being cared for. That's who I believe is in the best position to do it. As Dr. Virgilio said, ISS doesn't get calculated until sometimes weeks or even months later in some trauma centers. And I will point out to the level 1 trauma centers in the audience that I would say if I were to take a broad approach to this, the level 1 trauma centers seem to complain when there's level 2 trauma centers around them because they don't have enough patients. They seem to also be upset when there are too many patients coming to them. So the question is how to get that right. And actually, I think it is, and you're a 3rd-year resident, so it's not fair to ask you this question, but you're presenting, okay? So, you know, you mentioned the hospital's overrun. I guess if the hospital is really overrun, how to address that in your trauma system that gets the right patient to the right hospital in the right time with the right care. And the last editorial I'll make is that I think level 1 trauma centers and level 2 trauma centers, tertiary trauma centers, often underestimate the care that they provide. Those data you showed are mortality. What if I were to say, it'd be interesting what you think about this, that the main advantage that level 1 and level 2 trauma centers bring is doing simple things well. Simple things well. And there's a group of patients who don't get picked up, who basically don't get sent to the level 1 trauma center, who have missed injuries from a blunt small bowel injury, or who have a wound to their extremity being cared for by somebody who never deals with a complex soft tissue wound. And then that patient gets septic and dies unbeknownst to the level 1 trauma center. So I'd be interested in your group's thought on how to get it right in your hospital, in your system.
So in addressing that question, I mean, it's always going to be patient-centered, right? If you have a patient that the tertiary trauma center is very, very concerned about, you're never going to say no. Again, this is a retrospective study and has not been validated, so we still have a lot more work to do, and it's just a starting point. But in order to get it right, I think it's just going to take education, conferences like these. And then I think teletrauma, again, telemedicine is going to be a key in all of this to make it work.
Dr. Edward Cardale.
Good afternoon. Dr. Watkins, congratulations on your work, an important topic. A couple of comments and a question. Most of us believe, regardless of what center you're at, that patients who are at risk for major injuries should be observed for those injuries at the center that's going to take care of those injuries. And therefore, when we review a paper like this, I'm always careful to not accept the premise that if someone is transferred, let's say somebody who's had a head injury, brief loss of consciousness, very small intracranial, site of intracranial hemorrhage or small epidural. Awake, alert, Glasgow 15, hemodynamically stable. That patient by regional protocol is transferred to the center. Gets a second CT sometime during that 24-hour period post-transfer. They're now 36 to 48 hours post-injury, and they go home 24 hours or less from the new center. Someone does a retrospective study and says, aha, that was an inappropriate transfer. That patient went home without a procedure in less than 24 hours. I lived through that when we did the issue with how you bill for so-called observation. There's a lot of work that we do in trauma centers ruling out injuries. And then someone comes behind us and said, well, that was obviously an inappropriate admission. You never did anything, you just watched the patient. And then once or twice a year, you get somebody who really needed it and they were in the right place. And so with that comment, my question is, what were the major injuries that led to the transfer in the first place? So there's some occasional non-op blunt organ injuries, head injuries. Do you know a little more about who these patients were that were getting transferred and what their original injuries were? Congratulations on your work.
Thank you. So all mechanism, I mean, there are multiple mechanism of injuries and all, I mean, it was over 4,000 patients. There in our paper in the appendix that we have every single mechanism of injury listed out, whether it was getting run over by a cow, whether it was getting stabbed, every single mechanism of injury. We went through every patient, all 4,000 of them. So I can't tell you exactly which ones had the specific injuries requiring transfer, but it's just based on the same registry that it's the traumas, the transfers that you always get, the wide variety of trauma transfers.
Thank you very much.
Is there harm for inappropriate transfers?
I mean, there is harm because you're also getting delayed care if you need care, if you need observation and you're traveling 4 or 5 hours to go to this level 1 trauma center. It's important that you're getting care that you need. And then again, I think financial harm is one of the biggest issues you can have, especially when the study we're looking at is uninsured patients are more likely to be transferred, which shouldn't be what's important. And that's not a variable we looked at, but there have been studies that show that. And so, I mean, there is definitely harm to the patient when they're being transferred unnecessarily. Thank you.
I was gonna let it go and not say anything, but then you said one last thing, that there is harm that the patient encounters, correct me if I'm wrong, when they're transferred and they don't need to be. Is that what you just said, that very last statement? So,
Sometimes, yes.
okay, so I think what we're all trying to say here, or trying to make sure that we get across is we don't care if there's harm just by the mere fact of being transferred. What we care the most about is that we don't accidentally not transfer and the patient has real harm. Okay, yeah, they got a bill. Yeah, the grandpa had to drive an hour to get to them when they could have stayed where they were. We just don't want to do harm. At the end of the day, we don't want to do harm to the patients. And sometimes not doing harm, they get transferred. And I probably shouldn't be saying anything. I told him I was going to be quiet, but that last statement just bothered me, that you can transfer my mother or my father or my loved one if you're concerned. If you're the doctor, look at them and say, I'm concerned. Dr. Stewart.
Well, come to the mic. Come to the mic, please. Come to the mic.
Never turn anybody away. But when you saddle a 25-year-old with a $50,000 bill because you flew them in because you didn't really want to deal with it, it's Friday night, and the other studies like in the Northeast and New Jersey show what time do people get transferred the most without insurance, without injuries? 12 a.m. to 4 a.m. Now, could be convenient or it could be not. But it's not about harm physiologic. We're just looking at patients who really were transferred for convenience or whatever other reasons. Because financially, it's easy for you to say, well, I'll pay a $25,000 bill. I'll call my accountant tomorrow and I get the money. But you got a 20-year-old who suddenly they've gone broke because they said file bankruptcy. That's harm. And so it's not about not wanting to take care of patients. It's about making sure we do the right thing. And it's also, paving the groundwork. And this is a tool. It's not like we're going to say no. It's a tool for the other outside centers to say, maybe I can do teletrauma versus flying them in, for $30,000 bill.
Yeah, no, thank you very much. Great discussion, great paper. Thank you.
Like two quick announcements. Dr. Watkins that we just heard from is a Jack Barty finalist, and Dr. Crayley, who presented prior to that, is also a Jack Barty finalist. Now we will have Dr. Angela Lee presenting implementation of entrustable professional activities, a quality improvement approach from the University of Texas Health Sciences Center in San Antonio.
Thank you for the opportunity to present. I have no disclosures. So I had the chance to go skydiving in New Zealand. Although it may look like I'm terrified, I was confident that I would get down 17,000 feet to the ground safely because I had done my research. I found out that the company was certified by a trusted governmental agency. My tandem partner had reportedly performed over 9,000 jumps. And I also made sure to watch 8 other people get up on the plane and come back down in one piece before I decided to go. All of this reassured me that the team bringing me this experience was competent. To liken this very loosely to the surgical world, patients also deserve a surgical team that's competent. And this is ultimately the goal of a residency program, to graduate safe, competent surgeons. So how do we determine competency? Well, similarly to knowing that my dive partner had performed over 9,000 jumps, we want residents to perform a certain number of cases before they graduate, as defined by ACG&E. While not the best measure of competence, it is a commonly used surrogate. Trainees should also be tested by trusted agencies with the ultimate goal of obtaining board certification. But if you're not a program director, why should you care? Well, we also need to know how they're performing in actual clinical care. And for this, we rely heavily on faculty evaluations. So imagine you're a faculty member, you're finally ready to sit down and fill out this 12-page end of rotation evaluation form. You get this question that's asking you to evaluate your resident, Angie, on her tissue handling. And so let's say Angie demonstrates good tissue handling very consistently on straightforward gallbladder cases. But she's a little bit more inconsistent when there's extensive inflammation. She's also better in open cases than she is in laparoscopic cases. So do you give her a 2? Do you give her a 3? Do you give her a 2.5? Let's just give her a 2 because that's where she's expected to be at her level of training. You can see how it can be difficult to provide a single evaluation on such a broad range of experiences. Entrustable professional activities, or EPAs, are units of competency-based education that have been introduced as a practical approach to assessing clinical skills, first introduced by Dutch educator Dr. Tenkate. Essentially, they aim to answer the question, do you trust the resident to manage this? This is a representative image of SIMPLE, an app for intraoperative competency assessments. After performing a procedure, the resident and the faculty complete the evaluation about the resident's performance with the goal of practice-ready performance in senior residents. Case complexity is also noted. So immediate evaluation in 3 questions is more practical than filling out that 12-page survey, trying to remember how the resident performed 12 weeks ago. But how does all of this tie in with our institution in San Antonio? Well, when we experienced the COVID surge, the 2021 class of graduating trainees in all surgical departments experienced substantially decreased case numbers in their first couple of months of training. And this led to concern about their competency in certain clinical areas. So how could we assess the graduating residents for readiness for practice given the limited case numbers? This was an opportunity for our institution to utilize EPAs as an adjunct to improve our clinical evaluations. The data were collected from October 2020 Forgot about this slide. So the objectives of our study were to determine if EPAs were feasible across all surgical training programs at our institution, to identify and address barriers to implementation, and to obtain program directors' perceptions over EPAs. The data were collected from October 2020 to June 2022 and involved senior residents in 8 core surgical specialties. Each specialty was asked to select or develop 5 EPAs, as not all specialties had well-defined EPAs yet. They were also encouraged to identify 1 EPA for a clinical area considered at risk because of the decreased case numbers related to COVID, and to also include an EPA for consultation. The evaluations for senior residents were done in a summative fashion, asking the question, is this resident practice ready? And the residents were to obtain 3 microassessments for each EPA. After year 1, the program directors from each specialty were surveyed and subsequently collaborated with the Department of Medical Education to address specific barriers to implementation. Out of the 906 total requested microassessments, there was an 81% completion rate, and out of those completed, 99.6% were deemed practice ready. There was a higher completion rate in the second iteration of this project. This graph demonstrates the overall improvement by specialty, with 4 specialties showing a statistically significant increase. 2 specialties retained a 100% completion rate. 67% of the evaluations reported case complexity, and out of those reported, only 6% were categorized as easy as 1/3. The 8 PDs were surveyed on a 5-point Likert scale and had neutral to positive perceptions of EPAs. The barriers identified in the PD survey included a lack of faculty support, more paperwork, as not all specialties were using an app such as Simple, and a lack of resident buy-in. To address this, we performed additional resident and faculty development, and to decrease paperwork burden, all evaluations were performed electronically in year 2. The Provides Consultation EPA was only available in paper form in the first year, and 2 specialties had a statistically significant increase in completion rates after the transition to the electronic option in the second year. And above all, crucial to this was the continued collaboration with each program director and department chair to support the use of EPAs and to adjust them based on the program's needs. So this project did show that it is feasible to implement EPAs across all surgery programs at our institution, and that the challenges to implementation that we faced were consistent with those in prior literature. And although EPAs were a new framework to almost all specialties, our PDs reported an overall positive experience. This project was a single institution study at a large academic center with experienced surgical educators, and only graduating residents were included, lending to a selection bias towards practice-ready performance. Competency-based assessments in EPAs are the decided future of surgical education. It is a change, and change comes with challenges. The initial adoption of EPAs will be met with resistance and varying levels of completion. However, a continuous quality improvement approach with consistent engagement is needed to sustain and incrementally increase use of EPAs. This project highlights the importance of effective leadership, necessary buy-in from faculty and residents, and how technology can be leveraged to facilitate this process. Thank you for your time, and I'd be happy to answer any questions.
Good work, Dr. Lee. For our invited discussant, we'll have Dr. Alan Thorson from the University of Nebraska.
Hi, Alan Thorson. Ooh, is that on? Okay, thanks. I would like to thank the Congress and the opportunity to preview and review the paper, and also to congratulate the authors on their work in what I find to be a very confusing area of surgical education in today's world. TNCATE, as you mentioned, has made a distinction between entrustable professional activities, or EPAs, and competencies. He states that EPAs, sometimes colloquially described as skills, represent specific activities in and of themselves. However, the skill, as defined by TNCATE, is the ability to perform a specific activity. An EPA does not take into account the attributes of an individual, such as knowledge, skill, and attitude necessary to perform that particular activity, but only the work that has to be done. As you stated in your discussion, an EPA is a task or a unit of professional activity that can be fully entrusted to an individual when competence has been demonstrated. Taking that one step further, Tenkate notes that an individual does not possess EPAs and then becomes qualified for a competency, but rather possessing competencies and being qualified in an EPA is the goal of medical training. That sounds like confusing talk to me. So the ACGME has established the 6 domains of competence. You showed one of those up there, to include patient care, medical knowledge, systems-based practice, practice-based learning and improvement, professionalism, and interpersonal communication skills. I've all heard a lot about those. The surgery milestones have 4, 2, 3, 2, 4, and 3 components respectively for each of the domains. Taken together, these represent a total of 90 checkpoints to be determined and evaluated for each trainee. And this does not include the steps that may be needed to evaluate the various EPAs that are necessary to establish competency within an associated activity comprising that EPA. Your paper indicates that the general surgery program, your program, used the Simple app for a disease-based assessment, and that was an electronic process, I understand, but then you used a paper form to evaluate the provides consultation. You did not comment on the particular data points in what the data points were in each PA, but you did mention that you had, everyone chose 5 EPAs and they had 3 micro assessments. So I assume that means there are another 15 data points added on to the 90 that we already have attributed to the ACGME and the Board of Surgery, so now up to 105 data points. Finally, I noted a rather non-committal neutral response from the faculty with questions including an administrative burden, which administrative burden could serve as a barrier to implementation of these EPAs, as has been noted by a number of other authors. So my questions, okay. How many data points were required in this exercise? I think maybe you presented that and I missed that when I read the paper, but you perceived the inclusion of EPAs in surgical training evaluations to integrate with the 90 data points already to be considered in a trainee evaluation. How will you utilize that information that you have generated to further improve the Milestones Project and competency-based training in your institution? Do you have concerns about the increasing administrative burden of resident evaluation on the impact of work and life balance, both for faculty and trainees? And finally, do you see a time when advancement in medical training will be based solely on evidence-based competency rather than the temporal guidelines that we have at the present time? Again, thank you very much for the information you presented.
Thank you for those questions. So for the first question about the data points, specifically about this project, given the background that we only had 10 months to really kind of figure out how to evaluate these residents in a time when you had decreased case numbers, we went more for a sampling of, some 3 categories that were kind of bread and butter to their specialties, 1 at risk, and then a consultation, just so that we had some kind of control across all groups. It definitely does not, provide a perfect example of how to assess competency, but it at least gave us an idea. So if someone was deemed not practice ready, that could be an area that, with the limited case numbers, any cases that come up from now until graduation, let's make sure we focus on that so that you can graduate better than you were when you first had these evaluations. And, with the expansion, so to kind of allude to our expert discussion from earlier, it gets worse before it gets better. Our hope is to have more than 5 EPAs, more than 3 micro assessments, so that we have a more comprehensive, holistic idea of the residents' competencies. But unfortunately, to get that ball rolling, we have to start small. And so that's kind of how we ended up with the number of data points that we did. For the inclusion of EPAs, I really had to hold back because my talk is not explaining the EPAs, and it is a very complicated framework, but essentially the EPAs are not a replacement for the milestones and competencies, but rather just an easier way to assess that in a way that faculty are more familiar with. And that is, can this resident manage right lower quadrant pain versus is this resident good at systems-based practice, right? It's something that the faculty are a little bit more familiar with and on a clinical level. And with the EPAs, at least in general surgery, hopefully with the expansion to the other specialties, the EPAs are divided into a preoperative, intraoperative, and postoperative clinical phase of management. And so hopefully we're able to integrate some of those other domains of competency in have they worked up the patient correctly? Did they communicate with the family properly? And that can be seen a little bit better in the pre and post-operative phases of management. We focused on the intraoperative because we were more concerned about, the residents being able to practice their technical skills in this case. For the administrative burden and kind of how it's in addition to the other things that we have to assess residents on, kind of like when we integrated Epic in our system, it was kind of a mess. It felt like more work at first, but then slowly over time, we found ways to make it more efficient. And so there have been some ideas proposed at institutions where you're cutting back on your 12-page evaluation to just 4 questions about professionalism and things that can't really be assessed well using just an EPA and using an app. But if you say complete a certain number of EPAs for a resident, then instead of doing your 12-page end of rotation evaluation, you would be just given that EPA data to review at the end of the rotation and say, is this a correct reflection of how you think the resident performed? And then you wouldn't have to do that evaluation form. Unfortunately, right now we kind of had to do both, but the hope is that we can transition over so that you don't have to do the very lengthy evaluation process anymore. And for the work-life balance, it's a fairly quick, once you get rid of that evaluation at the end, it is a fairly quick procedure. It's just the 3 questions and you can provide feedback through dictation. And there, I think it is a possibility that trainees would be able to graduate early if they are able to prove that they are competent in all these domains. So I think it's a possibility.
Yes, we'll take a quick question.
Yeah, I have a comment and a question. I hope it'll be quick. My name is Sue McLean from Texas Tech El Paso, and I've taught students, residents, and now fellows for more than 20 years. And I have a comment. For your example of an EPA, you showed the Simple app. That is also something called a point of encounter assessment. So what I found, especially when I was in charge of the 4th-year students, it's a real barrier for attending physicians to fill out a form, especially if it's on a computer. Nobody wants to sit down and fill out a 30-question form. And you said yours was 12 pages. People are gonna have a hard time getting people to do this. So I searched the literature and came up with a point of encounter assessment. Mine was on a index card, and we gave the students the index cards to hand back to the staff. So if they did good on rounds, if they went to a case, if they helped out with the central line, anything, they could just give the attending or even a senior resident the card right then and there. So it would have been nice if it was been on an app. I don't have an app developer at my institution, but the same thing is it took not more than 2 minutes for anybody to fill out the cards. And then myself as clerkship director, when I got those cards back, I had a good picture of how they did. Because in surgery, students as well as residents work with somebody different every half day. So to assign some attending, hey, I want you to fill out this, 30-question, 12-page EPA form, you're going to have resistance. So I would suggest if y'all are going to set it up, try to set it up as a point of encounter assessment, similar to the Simple app, because you'll get more buy-in. And then whoever is a leader or your CCC committee can take all those assessments together and actually get a pretty good picture of how they were doing. The only drawback is if you're right in front of somebody when you're filling this out, you'll tend to be a little bit more positive because you don't feel like writing negative stuff, unless it really is negative, then you can fill it out. But we had way more participation in the grading process from a number of people. Within 1 year, I reviewed it. I had 325 little cards. All the grades were on time, and it really helped me, and I think it helped the students too. A lot of them I could see by the cards, they improved throughout the clerkship, so I could write that down in their final assessment. And I did publish it. It's in Journal of Surgical Education, Journal of Education and Curricular Development. So what I know is there actually is a whole literature on this point of encounter assessment, and I think that actually works better than assigning a person to sit down at their computer and try to remember what happened all month.
Thank you very much. In the interest of time, we're going to move to the next presenter. Thank you very much.
Thank you.
Our next paper is also a Jack Barty finalist. Dr. Wilson from Carolinas Medical Center will be presenting end-tidal carbon dioxide is associated with central venous oxygenation under continuous cardiorespiratory monitoring in a porcine model of hemorrhagic shock and resuscitation.
Thank you, Dr. Mangrum and Dr. Wood. Early warning and tidal carbon dioxide is associated with central venous oxygenation under continuous cardiorespiratory monitoring in a porcine model of hemorrhagic shock and resuscitation. Here are our disclosures. So we all deal with shock. It is a state of inadequate tissue oxygenation and low oxygen consumption in the periphery. It is due to one of two problems, either decreased oxygen extraction or decreased oxygen delivery. In distributive shock, such as septic shock, the issue lies within decreased oxygen extraction, while in most other forms of shock, the problem is mainly decreased oxygen delivery. In this project, we focused on this relationship of low oxygen delivery and hemorrhagic shock in particular. This is to go back to some physiology from medical school, and this is the equation for oxygen consumption. And this just reinforces oxygen extraction and oxygen delivery as the main contributors to this, with cardiac output in this scenario being the main driver of oxygen delivery. But in a busy trauma bay, it's extremely challenging to figure out what a patient's real cardiac output and therefore their oxygen delivery is. We have a few methods for doing this already. We stratify hemorrhagic shock into 4 different buckets based on traditional vital signs like heart rate and blood pressure. This has a few limitations and can be confounded by the patient's age, comorbidities, medications, other injuries. This can make these physiologic responses extremely variable. But we've all had that patient who was fine until they weren't. We also have laboratory markers, such as the ones listed here, that are objective and quantitative, but none of these are immediately available or continuously monitored. End-tidal carbon dioxide, or EtCO2, is real-time, mobile, quantitative, objective, is readily available in most settings, and can be measured non-invasively. There's a great talk by the Denver Health Group on Sunday about that. In CPR, EtCO2 is useful for telling us that we are giving adequate chest compressions and that if we've achieved ROSC. In trauma, this has been studied pretty extensively recently as a prognostic indicator. And this recent multi-center trial showed that it was predictive of mortality in massive transfusion and outperformed some more typical measurements like systolic blood pressure and shock index for predicting mortality. Our institution did a study in a similar vein, also showing it was better at predicting mortality than some of those other lab markers like lactate and pH. And this has been looked at in an older study, the relationship of EtCO2 and hemorrhagic shock in animals. And this previous study showed that it mirrored oxygen consumption and hemorrhagic shock severity. But the measurements were taken at protracted intervals of 20 minutes, so it's difficult to really deduce the continuous relationship from this study. An additional concept here is that central venous oxygenation, or SCVO2, is another commonly used marker of shock severity. Essentially reflects increased oxygen extraction as oxygen delivery decreases. Is quantitative and continuous, but typically requires a central line to measure, and so is invasive. The aim of this study was to demonstrate a relationship between ETCO2 and SCVO2 under continuous monitoring during hemorrhagic shock and resuscitation. We used a validated porcine model in 8 swine that weighed an average of 43 kilograms. They were under general anesthesia with continuous fixed volume ventilation. And we placed precept catheters in the external jugular vein with an open cut down. These are specialized central lines that allow for continuous monitoring and recording of SCVO2. You'll notice in this picture also this, several of these pigs were very difficult to intubate even for our very experienced veterinary staff. And so a few of them did require an open tracheostomy. We measured the ETCO2 in line with the ventilator circuit, and this was also monitored and recorded continuously on our monitor. Then we placed 12-French introducer sheath in the right common femoral vein for the purposes of actually doing the hemorrhage and the resuscitation, and a contralateral arterial catheter. This allowed us to measure some other standard hemodynamic parameters like MAP. This is our study protocol. After placing all of our lines, we allowed about 30 minutes for stabilization and then begin our hemorrhage period. This was divided into a rapid hemorrhage period over 7 minutes, followed by a 13-minute slower hemorrhage period. This hemorrhage model has been previously described by Frank L. et al. And then we maintained shock for 30 minutes and resuscitated the pigs with autotransfusion and lactated ringers. Here are our results. Notably, one of the pigs' data was corrupted, but we were able to include 7 of the pigs in our analysis. We plotted the average % change of each of these variables over the course of the experiment. And I'm going to do a laser pointer. So I'll draw your attention to mainly the orange line here, which is ETCO2, and the purple line, which is SCVO2. We showed that these were associated with each other throughout the experiment. And notice particularly they're very closely associated during the first 500 seconds, or the period of most rapid hemorrhage. This is our linear regression. And again, this showed ETCO2 was independently associated with SCVO2 throughout the experiment and also during the first 500 seconds. Although some other parameters were associated with SCVO2, only ETCO2 was associated with this variable both throughout the experiment and during the very early part of hemorrhage. So in summary, ETCO2 has previously shown promise as an indicator of poor prognosis in trauma. It has outperformed other traditional measurements of shock severity, such as blood pressure and other labs, for the prognosis of mortality. ETCO2 has many advantages in that it is objective, real-time, available, and can be measured non-invasively. And then SCVO2 reflects increased oxygen extraction as O2 delivery decreases in hemorrhagic shock. This was the first study showing that worsening hemorrhagic shock is associated with a decreasing ETCO2 and SCVO2 in a prospective and continuous fashion, and supported our hypothesis that ETCO2 was independently associated with SCVO2. And finally, real-time changes in ETCO2 during hemorrhagic shock may mirror similar changes in SCVO2, indicating a worsening shock state. Thank you for the opportunity to present, and happy to take any questions now.
Our invited to discuss it is Dr. Dan Margulies.
Thank you. I'd like to congratulate the authors on an excellent presentation and for getting the manuscript to me timely. In the study, the authors performed analysis of end-tidal CO2 and compared that to other parameters during a controlled swine shock model. And they found, not unexpectedly, a strong correlation with SVO2 by directly measuring both. SVO2 is a useful parameter and variable to know, and as the authors pointed out, is used frequently in the ICU, but it does require invasive monitoring. And it's not generally applicable or useful in the pre-hospital setting. For those unfamiliar with it, it is the oxygen saturation, as Dr. Wilson pointed out, of the venous blood just prior to returning to the right heart, and as such reflects the balance of oxygen delivery, which is mainly cardiac output and hemoglobin level, and the consumption from the entire body excluding the heart's oxygen utilization. I have 2 comments and 3 questions. First, I do think this is an intriguing and forward-thinking direction of study, as you are really getting some important information without invasive monitoring. And however, the end tidal CO2 studies that were published before mostly were done during anesthesia, during ventilation, with relatively normal pulmonary status. In this study, the patient is injured and bleeding, and the end tidal CO2 clearly reflects that, but the pulmonary circuit was normal, which leads me to my first question. In the face of an abnormal pulmonary status, such as pulmonary contusion, pneumothorax, or hemothorax, as is common in trauma, how would the end tidal CO2 change? i.e., couldn't it be lower based on the pulmonary dysfunction and not necessarily reflecting SCVO2? Secondly, why did the end tidal CO2 return almost to normal before the resuscitation began? You mentioned compensation, but could it also reflect an increase in the CO2 production overall? If that were the case, it would appear normal while the patient remains in extremis. And lastly, although the parameter falls rapidly initially, it also recovers quickly, reflecting the compensation mechanisms you mentioned. In fact, at the end of the shock state in your experiment, at 30 minutes, the end tidal CO2 was almost back to normal, while cardiac output, mean arterial pressure, heart rate, and SCVO2 were all still abnormal. Given that the end tidal CO2 monitors in actual trauma is unlikely to be present in the initial drop, does this limit the utility of the parameter for the early phase of hemorrhagic shock? Or would it be useful to be more useful to clue in the clinician in a subsequent bleeding episode? I'd like to thank the Southwestern Surgical for the opportunity to discuss this paper.
These are all truly excellent questions. So to start with your first question regarding the relationship of a lung injury and the usefulness of ETCO2, we know from the ARDS literature that intrapulmonary shunt has to be very significant, over 50%, to affect the alveolar gas exchange with CO2, unlike with oxygen, which is very sensitive. Indeed, we could see an injury that's this significant in trauma. It's easy to imagine still. But although this is easy to imagine, we would actually expect the ETCO2 to increase as it's inversely proportional or inversely related to alveolar ventilation. And so if you were to theoretically, if you were to still see a patient have dropping ETCO2 in this scenario, this would be a reason for concern. For your second question, this was regarding the gradual return of the ETCO2 to a baseline over the course of shock. This, we think, is related to the multiple factors that are affecting CO2 production, as you alluded to. So in addition to the CO2 that's produced from cellular respiration and metabolism, we also have a buffering system in our blood through the Henderson-Hasselbalch equation. And the bicarbonate in your blood buffers the increased lactic acid as your anaerobic metabolism kicks in. And then it gets converted into CO2. So in this way, you do get increased CO2, and that's part of the reason we see that CO2 start to rise towards the baseline during the shock period, and has been talked about in some of those prior papers before. For your last question, as far as when or in what setting this is actually useful with monitoring ETCO2. I think a lot of the clinical studies that have been done so far in trauma, some of those I mentioned in the introduction, and the study on non-invasive ETCO2 that the Denver Health Group on Sunday, so trauma patients, but none of those studies really address the physiology going on with this process. And we published one of those papers too, so we know that. But here, this study is a basic science study. We're really trying to get down to the physiology of what's going on and why this might be a useful indicator for outcomes in trauma. And I think we have taken one step in doing that in this study. We do have to, when we look at these physiology variables, we do have to control for a lot of things, kind of going back to your lung injury question. So, this is kind of a first step to study this model of hemorrhagic shock. But, reproducing these results in multiple different kinds of models would be ideal and it's always a goal for adopting these practices in the clinical practice. So.
Thank you very much, Dr. Wilson.
Thank you.
This concludes scientific session 5. I would encourage everyone to return at 2:30 for scientific session 6.
And Dr.
And
Cross
a
has
quick
something.
break across the way and come on back. Thank you to our moderators.
Thank you.
Yay.